Okay, welcome to H4N. Thank you
Good evening.
for coming here. Thank you, Brandon. And with us today, we have Dr. Jess Armine. You and I have spoken at length before, Dr. Armine.
Mhm.
It's fascinating to talk to you. I've seen you've actually sent me a lot of your, some of the materials, the education materials that you have, and they're just all fascinating.
Thank you.
You truly, I didn't have I don't know if I had the chance to tell you this, but you know you uh, I forget the phrase you use about being a neurotransmitter expert, sort of. I forget the phrase you
One
use.
of my one of my nicknames is the neurotransmitter whisperer.
Whisper, that was it.
Ah,
Yeah, the neurotransmitter whisper, and I love it because I love neurotransmitters. Like, I think a lot of people
Mm.
on the show know that I love dopamine, oxytocin, serotonin, and endorphins. I talk about it all the time. I talk about the
Mhm.
pervasive nature, about how it controls human behavior,
Mhm.
I absolutely love it. So when I go over um, a lot of the education that you sent us, a lot of the presentations, you have these complete dopamine or just neurotransmitter, like how everything is synthesized and all the different pathways. And I
The
just
pathway.
there and I just like just looking at it, trying to figure it all out, and saying, "Hey, what is BH4? Like, how does that do? And like, how does that come into play? And how does this come into play with COMT? And what and like so a lot of these pathways are just fascinating to me. And I took a lot of
They are.
I actually have probably put hours and hours into all the slides you created, including some of the previous ones that you sent. So, but it's been fascinating. I've learned a lot, and
Wonderful. Thank you.
so this is going to be fantastic. You know what I didn't think is, after this, Doctor. I mean, we'll get your information as far as any like contact, if people want to contact you, right? And we'll put that in the
Sure.
description of this, so people will be able to contact you if they want.
absolutely.
Sure. Thank you.
And of course, like another thing we'll of course think about is, do we want to, we can always talk to you about possibly offering your services, whether it be just like a referral basis, right? Like, we've had this
Well,
person that we refer these situations to. I can actually think of a couple of people who would probably be great referrals to you.
mhm.
Yeah, one of them is sitting in the chat as we speak.
Oh, okay. Oh, yeah. Yeah.
I can see.
I have to say, when
Yeah,
you said I love
I'd
love
be grateful if.
Sorry, go
Yeah.
ahead.
Sorry. No, I was just saying I would love to work with you on a consultant basis. I don't.
Yeah.
That's where I work with a lot of different physicians, basically as a consultant. And they have complex cases, and I help them through that. And yeah, neuropsychiatric conditions are, my ultimate specialty, if you will, because I have some schizophrenia. So that was one of the first things I learned, and then all the genetics and everything else came in after that.
I wasn't aware that was the genesis of your interest. That's yeah,
Oh, yeah.
I can understand. I can understand why that's so
It's
important to you.
it's always a powerful stimulus.
Yeah.
Absolutely.
These neurotransmitters are pervasive in human behavior, and that's lost on a lot of the education. Like, a lot of human behavior
Mhm.
can be boiled down to these neurotransmitters, and what actions are inducing uptake of these neurotransmitters. So it's like our actions
Mhm.
produce an uptake of these neurotransmitters in different fashions, and like, just understanding that helps you understand, like, a lot about human behavior and how to feel good, right? So, like, you can take this and understand, what actions do I need to perform to have a good sense of well-being, and to really garner respect, admiration, and good sense of well-being throughout my social, my social aspects, and throughout society. When,
Everything's balance. Everything's homeostasis.
you know,
And when you talk about neurotransmitters, okay, the one of the best ways of telling if you have a problem is that if you're having depression or anxiety for no reason, okay,
Mm.
there's situational depression, break up with a boyfriend, whatever. Okay, but if you're just having it consistently, a consistent low level or consistent, anxiety or anxiousness, for no psychological reason, a social reason. And then that's a physiologic reason.
Yeah.
And that goes down to neurotransmitter balance, receptor function, and so forth.
Yeah. And that's in the context of disease states, right? Like, or where there's some issue that we have to overcome. And I'm even talking about, and that, that's important. That's important to understand, important to know how, like when we have to intervene either through nutrition or even medication. And that's important to understand, right? But also just in the context of just kind of normal, I'm having like a malaise right now. Like, how do I get over that? And how do I understand?
Exactly.
How do I understand just kind of quote unquote normal depressions or when I'm excited, like what is that? And how do I tilt my, my life, my feelings towards feeling good most of the time. Right. And there's certain things you can do. It all comes in action. It comes in, and the main thing is helping people, right? Because we evolved to be social creatures. So we evolved that we produce dopamine, especially oxytocin, from helping people, helping others survive. We produce these neurotransmitters to help ourselves in situations where we help the survival of ourselves or the survival of our species, right? So when we help others survive, you get these dopamine, oxytocin, uptakes. And helping people, right? It gives you dopamine, oxytocin. It gives the other person dopamine, oxytocin. Then every time they see you thereafter, there's these connections that are made, and you get little dopamine hits every time you see that person. They say, hey, they give you extra special. Like we take in these subtle social cues of people respecting and admiring us, and that gives us dopamine, oxytocin, right?
It's that form of bonding.
And when people compliment you, or when people say, hey, thank you for helping me, and it makes you feel good, right? It gives these dopamine, oxytocin. So the more people you help, the more of these little connections you're making, and the more, like I like to call a diverse portfolio of dose responses, right? Like when the more people I help, the more people that I've helped and formed connections and relationships with, the more diverse portfolio of these dose responses I have. And it just gives you a better sense of well-being. Everywhere if you're helping people, everywhere you go, you're getting these little dose responses from people. And it just gives you a better sense of well-being and overall better outlook on life. And you just feel better, right?
As they say, some people cause joy wherever they go, others whenever they go.
Yeah. Yeah.
Right.
So I think even in the context outside of disease states, I think it's like understanding these neurotransmitters and what they are and how they're naturally produced can just give you kind of a blueprint on how to live a better life, or give you a better sense of well-being.
And that is precisely the goal of our live stream this evening. In case anyone just tuning in has not figured it out, Dr. Armine is an expert in not only genetics, but he is the neurotransmitter whisperer. And he has been so kind to take, I'm assuming, quite a bit of time to prepare a very interesting presentation for us. So I would love to cue that up for Dr. Armine. But before we do,
thank you.
We should say hello to some of the our favorites in the chat.
So there's Athanatos kind of expounding on what we were just talking about, right? Be nice and helpful and get high. That's exactly what it is. Actually, you're like that's what drugs do. When we get high, they're artificial uptakes of these neurotransmitters. That's what being drunk is. A huge uptake of dopamine. So is cocaine. Huge uptake of dopamine. The problem is it gives you these artificial highs and kind of gets in the way of, you're supposed to do something positive in order to get these neurotransmitter uptakes. And when you just take a drug to get them, then your body your brain says, go do the action that got me that uptake. And when it's helping people or helping yourself survive, that's positive. That's a positive addiction, right? You get high positively. When it's just taking a drug, your body says, just go do that drug again. Like, keep doing the things that gave me that dose, that dopamine or serotonin or whatever uptake. And if it's taking a drug, you just get focused on taking that drug instead of doing the things in society that give you those uptakes naturally. But this was a great.
Sadly, we're taught to take a pill for the ill, and the medications work on receptors, and they go on, they go off, So you're not getting the effect naturally. And what you're talking about with doing the right thing, feeling good, there's a theory out there that cells are being created and destroyed all the time. That people with depression create cells that engender depression, and people who are happy create cells that are happy. Now that's a theory, and there's also theories about pathways that are created when you do things over and over and over again. But it doesn't really matter, because the same thing you do to get there, the more you practice and the more you do that, and the more you get those positive responses, it stimulates you to continue to do those actions. And that's one of the ways of fixing this.
Yeah, that's great. So saying hi to some people in the side, we have Boston Sean here. Are his genetics holding him back? That's what he wants to learn today.
We're gonna find out, and I'm gonna let you all know about it.
Ruben Baca is here. Cool. No Acre is here. He was on our show a couple weeks ago. Boston Sean.
Wonderful.
Winnie DWC is here. No Acre's got a good question. We'll get to that. Anthony, this is our newest health maverick. Anthony is here. Good to see you, Anthony. Thanks for joining the show,
man. We're very excited to have him, and we appreciate him dedicating some extracurricular time to watching.
Yeah. Of course, Zionic is here.
Zionic, how are you?
Yeah. Okay.
That was a great tagline.
Thanatos, of course. He was the one that gave us that. And again, okay. Anthony, nice to see you guys. Okay. Okay, so Brandon, should we start with the presentation?
Absolutely. Let me bring that up.
Okay, we're gonna let Dr.
Jess
Jess
this view works. Yeah, hopefully this view works for everyone. Doc, if you just tell me when to scroll, I'll scroll for you.
Mm-hmm.
Okay, great. All right, guys. We're going to be talking about genetics today. And first thing you need to know is genetics are not your destiny, and I'm going to tell you why. Okay? And then what they mean and how you optimize with them. But bear with me, because you're going to learn an awful lot today about how to look at your genetics. Next slide, please. Okay, you heard that I'm the Neurotransmitter Whisperer. That was a nickname that one of my patients gave me a long time ago when I read her neurotransmitter study, and I told her all about herself. And she said, I know who you are. I said, oh, the Neurotransmitter Whisperer. And it stuck. Okay, I've been a healthcare provider for 50 years. I've been an EMT paramedic. I've been an RN, which I've done mostly emergency and critical care work, and I've been a chiropractor since 1986. My present expertises are in epigenetics, forensics, methylation, neuroendoimmunology, which I'm going to teach you about today, functional medicine, and so on and so forth. Basically, what I do for a practice is diagnose and treat complex multifactorial illnesses that have not achieved success elsewhere. That's why I'm really known as the Sherlock Holmes of chronic illness. Because I'm the guy they come to when they can't figure out what's wrong. Okay, next, please. Okay, so let's talk about genetics. What does it even mean? Okay, what are these SNPs or polymorphisms or genes and pathways? What do they mean? Next slide, please.
Oh,
okay. This is where I learned how to do genetics. That's why I don't have any hair anymore. Okay. This is Roche biochemical pathways. Okay, and guess what? They're overwhelming. Okay, it looks like a big railroad tracks of how everything interacts. Okay, and this is where we first learned about genetics, and it was crazy. But we can simplify this. Next slide, please. Okay, let's talk about real basics. What genes are enzymes? Genes create enzymes. Okay, so if you have something like MTHFR, that creates an enzyme called MTHFR. Okay, and enzymes change one thing to another in the body. So when something goes down your detoxification pathways, it goes through several changes before it gets detoxified out of your body. Okay, so what the enzymes do is give your body what it needs in the form that it needs it, and that's how you have energy, mood, detox, hormones, and so forth. So your genes create enzymes. The enzymes determine how you feel. Next. Okay. I know it's a little hard to read, but let me just point it out. Look at the top here. It's kind of small. Can we make this bigger, perchance?
That I'm not sure about.
Don't worry about it. These SNPs, single nucleotide polymorphisms, or polymorphisms, are, I use those terms interchangeably. You'll see them as SNPs. When you look at a genetic pathway, okay, we look a gene up here, a little hard to see it, but these first, the orange ones here, these are all MTHFR, okay?
Right.
And you'd see MTHFR, and then a variant, which is a bunch of little numbers. And this was coded by the Human Genome Project. And what you would see here is the RS number, which is the number given by the Human Genome Project, the gene, its variant. And when you look at this, some of them are green, some of them are red or pink, and some of them are yellow. Well, there's the gene has the alleles, let's say here AA. Okay, there is a risk allele or something that would tell you that it's a little off. And if it was AG, it would be yellow. And if it were GG, it would be red. What does that all mean? Next, please. Okay. This is what all those SNPs actually mean. What they mean, these are the estimate of the enzyme's innate function. In other words, how well the enzyme will act. Now, normally the green, think of it as an 8-lane highway, okay? And if it's yellow, which means that one of the risk alleles are there, it's heterozygous, which makes it 60% function, but think of it as a 4-lane highway. And the homozygous, think of it as a 2-lane highway. So I submit to you that you were born with these genes and these variants and their SNPs. But when you were a baby, it wasn't a problem. Why? There wasn't any traffic. Okay, so if there's no traffic, what's the big deal? Next slide. But obviously, if you have traffic, a 2-lane highway, homozygous, is going to block up quicker than a 4-lane highway, which is heterozygous. Okay, when I say words, I'm going to say them fast and slow. Just ignore the big words, okay? It's not important that you understand the words. It's important you understand the concept, okay? And if I say a big word, I'm going to say it really fast. Okay, I'm not trying to sound condescending. I simply want you to ignore it because the big word means nothing. I'll explain it in the next few seconds.
That's okay. We have a lot of nerds in our audience, so it's
okay. Well, then I'll say the big word.
Yeah.
I'll say them a little slower. By the way, guys, I'm consistently jovial, and the reason for that is I believe that disease is a bully, and that if you want to take care of a bully, you punch it in the nose or you laugh at it. That's how you take away its worst.
Good stuff.
Thing about chronic illness, which is like
your neurotransmitters are optimized as well. That's why you're also
absolutely. So this traffic is things like bacteria, heavy metals, viruses, parasites, food allergens, candida, leaky gut syndrome, so on and so on and so on. In other words, oxidative stress. Chronic inflammation and oxidative stress, reactive oxygen species, reactive nitrogen species, and all this good stuff, all the same thing. The more it gets into your pathways, things are going to block up. And the normal pathway, the 8-lane highway, do you think that could get blocked up? Next slide.
A lot harder.
Yeah, I think.
Yeah.
Okay. So just because it's green doesn't mean you're good to go.
Yeah.
If there's enough oxidative stress, that pathway is going to get blocked up also. That's why you have to correlate things.
Yeah.
Okay.
And
so
on this slide, you kind of highlighted what can still block out, even if your pathways are wide open, right? Here's all the stuff that can block this up, right? The bacteria, the heavy metals, the viruses, food allergens, right? Leaky gut,
substrate, like the cofactors.
Environmental toxins, poor diet, especially
insulin resistance. Yeah, obviously,
is huge at creating inflammatory or defense proteins. We're going to talk about how your body goes into defense mode, and the biggest culprit of that is insulin resistance, right?
It's what creates the insulin resistance also.
Yeah.
The end result is insulin resistance, which then causes other problems. But the original problems that cause insulin resistance, which I'm going to be mentioning in a few minutes. Okay.
All right.
So if we go to the next slide, please. Okay, so you put it together. So if you look at the normal, let's say green, yellow, and red, normal, heterozygous, and homozygous, it's all a matter of how much oxidative stress there is. Next slide. So the SNPs or polymorphisms are really only relevant in relation to how they function within the pathway, the presence or absence of cofactors and coenzymes, which are vitamins and minerals, which have to get into the cells to be, that's what makes the enzymes work at speed.
Right.
They'll work, but with like magnesium, calcium, B1, B2, B3, B5, B2. Okay. If you don't have those things, if they're not getting into the cell, into the mitochondria, your biochemical pathways will slow down, and even a smaller amount of oxidative stress will interfere with it. And there are other factors that upregulate and downregulate things.
What you're talking about right there, like, it seems to me, is one of the biggest factors. You talked about all these cofactors, enzymes, you know, substrates, right, that have to get into the cell, or also the like the enzymes, a lot of the DNA, the mRNA transcribes into a protein, or I'm sorry, God, now I'm having a brain fart here. The mRNA, it's transcribed into mRNA, and the mRNA translates into a protein or a peptide, right? And these proteins or peptides have functions for the greater body, and they have to get out of the cell, right? Sometimes, unless it's if it's depending, a lot of them have to get out of the cell. Anyway.
Everything happens within the cell. Everything happens within the cell. Okay. And the cell will throw things out. But you're talking about, and your point is well taken, because what's necessary is substrate first. Okay.
Yeah.
Which is digestion. If you don't break a protein down to its constituent amino acids that it can be absorbed and have the body reestablish the proteins that it wants by basically using them as building blocks. Okay. And you break them down to short chain proteins, which are antigens. Okay, you're the greatest creator of your own antigens.
Yeah. Yep.
But you're not digesting well. Okay. And there's loads of reasons for that. So, and actually we're going to be addressing just what you said in about a minute.
Yeah. Okay.
Good.
Next slide, please. Okay, so here's the wisdom I've come up with. The presence of a SNP or polymorphism does not mean you're ill. You see that on a genetic test, it doesn't mean you're sick. Do you know how many people call me up and say, I have compound heterozygous MTHFR? I'm like, yeah. But I'm like, are you sick? Were you sick yesterday? No. Then you're not sick today. Okay. Or the lack of a SNP does not mean you're well. Okay. It's not just the genetics. I know that's blasphemy for people. Okay. But I've been doing this a very long time. I was at the very beginning of this whole genetic stuff. I can tell you from experience, this is the truth. Next slide. Okay. So what happens that creates the problems, the oxidative stress, the traffic? Well, the very basis of all illness is something called the cell danger response. This was a study that was done by Robert Navio, MD, PhD, in 2013. And what he did was identify everything that injures a cell. So it was divided into chemical and physical. Obviously, that makes sense. Heavy metals, BPA, and so on. Microbial, mold, fungi, bacteria, viruses, parasites. And believe it or not, he proved on a scientific basis all the psychological, emotional, and go back up, please. The psychological, emotional, and spiritual traumas that we face will injure the cell just as much as microbes, just as much as toxins. And mind you, a lot of people have multiple things. And in this time in history, because of COVID and the vaccines and so forth, we have to deal with the spike protein from COVID. And that is, believe it or not, a toxin. And you're hearing all the things about long COVID now, and how they're having turbo cancer, and how people are getting more, younger people are getting, pulmonary problems, heart problems, gut problems, and so forth and so on. The spike protein is pervasive. And I know exactly how to treat it. I just wrote a paper on it. And there are ways out there of actually detoxing from the spike protein. And unfortunately, we have to be cognizant of that, because traditional medicine, which I have no problem with, but traditional medicine is doing what it usually does. They're not treating it because they don't think there's a treatment. And it's being allowed to become the next chronic disease that has no cure, but we're just going to manage it. Okay. So I hate to be like this, but remember that when you're dealing with big pharma, a cured patient is a lost customer.
Yeah.
So they're managing chronic illnesses, not curing.
Not curing. Yep.
I would like to
All right.
stay at this for just a second here, or
Yeah, go back up to
even
the.
this is
By the way, that's sad cell. I mean, that's
yeah,
doing well.
it
It's
is
very cute.
It's bad. So in I've been studying this for a while, but I've been studying exactly what we're talking about a lot more.
Mhm.
And from what I am seeing is this the cell danger response, or the and are we, like, what about when cells are stressed, right? Especially like adipocytes, and in the case of insulin resistance, they're shooting out these stress proteins, right? That are
Mhm.
causing inflammatory tumor necrosis factor
They're sending out inflammatory,
and
pro-inflammatory
interleukin
cytokines.
6,
Yeah.
and then that's causing this
More cells.
inflammatory cytokine cascade, right? Which inflames all the cells. And from what I can see, this is a large part of the reasoning for like a lot of these fatigues and chronic fatigues and chronic diseases,
Absolutely.
right?
Absolutely.
So, and
Well,
exactly what you said before, the cells are expanding from these inflammatory cytokine storms, and then they can't function as well. Am I correct in understanding this? They can't function as well. Things can't get into the cell,
Well,
things can't get out of the cell.
let me reframe this for you to tell you exactly what
Yeah.
does happen. I didn't want to get overly technical, but you said you have some nerds here. So let me explain what happens when the cell is attacked.
Yeah.
Several things happen. The cell will tighten up to prevent, let's say, the microbe from escaping.
Mhm.
Okay, what it does is the inside of the cell becomes toxic purposely. Okay, because it increases its oxidative stress to kill whatever's in there. Okay, it releases something called hypochlorous acid, HOCl, which is what you use as a sanitizer, like for a baby, because it's very mild. But inside of a cell, yes, thank you. There's CDR1, 2, and 3. I'm going to talk about the mildest form at the moment. Okay, so it will play with it, but in the process, what happens is you can't uptake your vitamins. You can't get rid of heavy metals. Okay, it's purposely making the cell toxic. Then, when the danger is gone, we have a whole set of pathways that reestablish normal mitochondrial and cellular function. I call it rebooting. Okay. Now, what's the example of that? So everybody's gotten strep throat or some kind of infection. You go to the doctor, you feel terrible. You go to the doctor, he gives you an antibiotic, right? So he or she gives you an antibiotic. And you feel kind of rubbish for a few days. You start getting a little bit better. But then there's the day where you turn the corner and you start getting better rapidly. That's when the cell danger response has reversed itself. Okay. But go to the next slide, please. Sadly, in our society, very often we have either chronic or persistent cell danger responses or many cell danger responses. And the problem is it doesn't resolve. And when that doesn't resolve, the whole body metabolism is affected, the gut microbiome is trashed, all the organ systems suffer, behavioral changes can happen. But what you're saying at the cellular level, when the cell swells or the cells become leaky, that only means what's happening is that the sodium that's on the outside can get in and the potassium starts going out. So wherever sodium goes, so does water. Okay, and once the cell starts swelling, it becomes more dysfunctional, and with more pro-inflammatory cytokines, more inflammation, it's now you're in this vortex of constantly injuring the cells. And even if the root causes are gone, and you still have the inflammation, that's going to be the reason for the cells to be constantly dysfunctional.
Your body is actually signaling to destroy the cells. Like that's what the inflammatory cytokines are. Right. So it's like,
they do a lot of things.
You're in this defense war, I don't know, kind of mechanism, right? Where you're actually labeling all your cells to be destroyed. And that's what's causing all this. We have an alternate pathway. We have a repair mechanisms, repair and restore, and as you just termed it, reboot mechanisms. I think like one of the goals, right, is to shift macrophage 1, M1 state, which is war, destroy all cells, into M2, which is more of a repair and reboot, right?
You're absolutely correct. If you want to get down to what you're doing, but on a more practical level, okay, because somebody will say, well, how do you do that? Okay. You're right. That's the mechanism. But how do you create that mechanism? Is going after the going after the oxidative stress. Because if you take it in a more esoteric term, your body's energy will be spent more time fighting the inflammation than repairing itself. That's the real issue. And that's why cancer takes root. Because when you're very much inflamed, your immune system cannot recognize self from non-self. So
Good
little
from
cells
bad.
mutating are allowed to take root. Okay, that's why if you treat this at a cellular level, treating the oxidative stress, which should be the target, okay, by whatever various mechanisms that there are, you're going to help the body heal, because then when the inflammation starts dropping, now your body can initiate those repair mechanisms.
Yeah.
Okay.
So
next slide, please.
And I hope you're going to tell us how to fix all this. I'm excited.
I'll stay with you. So what I want everybody to know is that chronic cell danger response of whatever level creates inflammation, okay, which we term as oxidative stress. You're going to see it by a lot of different names. Next slide. And I want everybody to know that chronic inflammation is the base reason for most of the things that ail us. What does it do? That's the traffic.
Yeah. Okay.
So the genetic polymorphic pathways, the genetic predispositions are allowed to express because the genetic pathways, which you're going to go over in a couple of seconds, now are not functional, and that's where you start getting pathology. But this is just a very short, Alzheimer's, neurological disease, cardiovascular, autoimmune, pulmonary diseases, diabetes, autism, whatever there isn't a thing you can name that doesn't have inflammation at a base. Next, please.
I want everybody to know that I'm marking your questions here for and we'll answer them at the end when we'll answer these questions at the end. So thanks for your questions. Keep them coming.
Yeah, keep them coming, guys.
There's another concept that I'm going to introduce you to. It's called neuroendoimmunology, and it is a relationship between the nervous system, the immune system, and the endocrine system. It's how you maintain homeostasis. So the nervous system puts out neurotransmitters and obviously has the receptors for that. The immune system puts out things like cytokines, chemokines, and so forth, has receptors for that. The endocrine system puts out hormones, has receptors for that. But each of these systems have the receptors for each other's biomarkers. Okay. So the fact is, next slide, that these systems constantly talk to one another. And the fact is that when one goes off, the others are going to go off at some point. Okay. Next slide. Because they're constantly talking to one another. And I've been a scout leader since God's been a Boy Scout. Let me tell you something about little scouts. When they start talking, there ain't no shutting them up. Okay. They'll lower their voice, go in the middle of the night, you're like, quiet. Okay. Because they just want to camp, they want to use sharp objects, they're cool. Okay. But they're in constant conversation.
Yeah.
And what you really need to know, next slide, is an attack on one is an attack on all. Now, you start developing, an endocrine problem, Hashimoto's thyroiditis or something like that. If that's the primary thing, what's going to happen? Yes, that's going to be dysfunctional. But at some point, the immune system is going to be involved. At some point, the neurotransmitter system is going to be involved. I did a lecture at the Ultimate Hormone Conference on where do you go when you're doing your hormone therapy and it's not getting any better and you're doing everything right. Well, this is what I introduced them to, because the other systems need to be looked at. Next.
It's interesting.
Okay, so how do we assess the genes? I'm going to use MTHFR because a lot of people use MTHFR as a reason for schizophrenia, depression. It's the boogeyman. And I always tell people it's not a deity, it's not a devil, it's not waiting on the tall grass to get you.
Yeah.
Okay. But the thing you need to learn here is that no gene by itself, okay, does everything that you can look on the internet and says. So MTHFR, when they first started looking at that particular gene, they were doing it to see if it could predict high homocysteine, which is a cardiac marker. Okay. Didn't work out. And they studied 2 variants. And you saw on the other slide that there were 12. There were actually 50. So when you look at, let's say those 12, only one polymorphism in there, it's going to affect the function that much. Okay. And you need to look at it. You need to look at the pathway not at a single gene. Okay, next.
I like this because right now, especially right now, and especially even just I don't even in the last 6 months, maybe in a year, MTHFR was like you said, it was almost like deified or vilified, and it was like, here's the thing that, and you know what it caused a lot of people to do is just start taking methylated vitamins, even if you don't know if you have this condition, which can be bad, right? If you over methylate,
well, here's the thing. I'm going to point out when I show you my folate pathway that if you don't fix the pathway and just give somebody 5-methylfolate,
yeah,
you're going to have to give it to them for forever. And not everybody does well with methyl vitamins, by the way.
Yeah, right. Yeah, that's what I've seen.
And so you had asked me to talk about. Go ahead.
Sorry, no. So people just started taking these methylated vitamins just because they got scared. People, everybody on the internet was scared of MTHFR, right? Yeah.
Actually, it was ignorance. It was actually ignorance.
Right.
The medical profession, genetically speaking, epigenetically speaking, it's about 15 years behind us.
Oh, yeah.
We went through that thing. We have to treat the gene. You can't treat a gene.
You know how far they
we have to, like with the CBS, cysteine beta synthase for glutathione. We has stopped people from having sulfur, and we did it so horribly that people were getting low in sulfur and having problems.
Yeah.
Okay? I was a guy yelling at people saying, you can't do it that way. You can't do it that way. You have to let the body balance itself. They'd asked me to go relate dopamine to a lot of things. So dopamine will regulate libido. It inhibits prolactin. It regulates cortisol. At first, it'll knock cortisol up.
Yeah.
When it's chronic, it will lower dopamine. Okay, high cortisol will lower dopamine.
Yeah,
it has contribution to insulin and metabolism, and of course the sex hormone. So let's look at the pathway next.
Mm-hmm.
There we go.
This is a little technical, but let me go over it slowly. Okay, the pathway is phenylalanine, which needs BH4. The big word is tetrahydrobiopterin.
Yeah.
Okay, and iron to run, and this enzyme is called phenylalanine. They call it pH, phenylalanine hydroxylase, okay? Then it becomes tyrosine, which needs BH4, oxygen, and iron to work.
Yeah.
And it creates L-DOPA.
Yeah. So the tyrosine hydroxylase is the rate limiting step in creating dopamine, right? So that's why testosterone increases testosterone hydroxylase, and then that gives us an uptake of dopamine, right? I think that's a really important step in all this. Sorry.
It is.
Mm-hmm.
And this creates L-DOPA, which then creates dopamine. Okay, and dopamine beta hydroxylase, which I'm going to show you in a pattern, breaks dopamine down into norepinephrine and epinephrine. So understand that.
I'm sorry, I apologize. I like to interject when things are relevant. So the L-DOPA pathway, right? We give Parkinson's patients L-DOPA, right?
L-DOPA,
right? Because the reason, the motor function is when we have really low dopamine, it interrupts motor function, and that's what Parkinson's is, right? So I think this is all really relevant to real.
That's very, very low. That's very, very low dopamine.
Yeah.
Relatively low dopamine will give you a very severe depression.
Yeah.
Low serotonin can be a depression, but that bipolar depression, that's low dopamine. Yeah. And just in case anybody's wondering, the way you tell the difference historically is if somebody has depression and can be brought out of it by taking them to dinner, that kind of stuff, and they feel better, fine. But if they have anhedonia, which is a lack of joy, and what you have to do is ask somebody, listen, the things that used to make you feel better, do they make you feel better now? No. Mm-hmm. That is low dopamine and is a very low depression. So if this is normal, slight depression is called dysthymia, then there's depression, then there's that deep, major depressive disorder. Next, please. Okay, so this is what the pathway looks like, okay? And we're going to get into how one can predict what's going on. Mm-hmm. All right? Again, it's a little bit different, so I'll just go over tyrosine, L-DOPA, to dopamine, to norepinephrine, okay? So when you get to the dopamine portion, okay, DBH, I tried to make this red, sorry. Let's say somebody has polymorphisms or SNPs at MAO, COMT, and DBH, okay? What's going to happen here is they're going to have very high dopamine because it simply can't break it down. If they have a reason, whether it's microbial or whatever, to have this system kicked up and creates a lot of dopamine, okay, they're going to, because they can't break it down to norepinephrine and go down this pathway, they're going to have high dopamine. So two things are going to happen. I can predict this. Okay, if I'm looking at it and saying, okay, the high dopamine will give them anxiety disorders or what I call excitatory disorders, things like
Sure.
OCD, ODD, oppositional defiance disorder. Okay, when it's just slightly high, and paranoia, and as it gets higher, getting into hallucination stage, and even higher, you're talking about autism. Okay, and at the same time, it can't break it down. You'll have a high dopamine and a low norepinephrine, which is going to give you attention deficit disorders. Okay, and that's because we need norepinephrine and phenylethylamine for our focus. That's why the amphetamines that you give to some hyperactive kids works very well, because what they need is coming out of the adrenal gland, epinephrine and norepinephrine.
Okay. So
but that's not the way of going about it.
does the norepinephrine also it puts you into a sympathetic state, right? Like so too much norepinephrine will put you in fight or flight, right? Anxiety.
All of this is putting you into chronic fight or flight.
Yeah. Right. Okay. So
you know.
So when we look at, I want to interject for, this is relevant to a lot of our patients, right? When, and there might be a better slide to do this. So let me check the next one. I don't know. So, but this is relevant to some of our patients, right? So estradiol slows down this COMT process. And what you're talking about is if you have a problem breaking down dopamine, you're going to have what? You're going to have more dopamine, more norepinephrine, more epinephrine, which is going to put you into a sympathetic nervous state. And then you'll kind of be in a constant fight or flight state, right? So estradiol also slows down this COMT process. Now, this is good to an extent because it allows dopamine to exist in your cells more, but too much, and then you have problems, right? So this is why when people have really high estradiol, they start feeling anxiety, right? You start getting this anxiety, like, oh my gosh, it's because we're slowing down this COMT process to the point where you have too much dopamine, norepinephrine, and epinephrine left over and staying in your cells. So I think that's relevant because a lot of people, when their estradiol gets too high, they have anxiety, and we have to like bring it down so that they don't. Okay, sorry.
So the thing I want to point out here is if you want to get this pathway to work better, there's a couple of things you can do. That what I listed here were the cofactors and coenzymes that are necessary for these enzymes to work. Okay. Also, you want to give them or help them build the opposite, the inhibitory. So if you have high dopamine, the natural way of treating it is raise serotonin because they balance each other. And and by the way, if you've had high dopamine for a while, you're using up your serotonin. Usually in that kind of condition, you're going to have leaky gut syndrome or some kind of gut problem. 80% of your serotonin is created in the gut.
Yeah.
So now you have a real problem. You're not manufacturing it. You're using it up really well. And guess what? Okay, you don't have your inhibitory response, so you can't balance it. Everything's a balance, like what you said with estradiol. Progesterone actually kicks up GABA, okay, the inhibitory response. That's why many women who are in the menopausal range, who have anxiety, are given progesterone. Okay, not enough to let them have their period, but enough so that the hormonal balance is recreated. Next, please.
And sometimes we give menopausal women enough to have their period, and then they freak out.
Well, yeah, that's happened to me too. But hey, what are you gonna do? Anyway, when you're looking at
everything's happening the way it's supposed to, right? Like
it's a game of adjustment. It's a game of adjustment.
It's happening the way it's supposed to. So like, but when 7-year-old starts cycling again, like sometimes they get freaked out.
They think
it means you're healthy.
It does, but it's also very scary because if you haven't had your period in a long time, you start getting
disconcerting. Yeah, to say the least.
You start thinking things of cancer.
Everything's working the way it's supposed to.
Right. Well, the reason I put this up, this is a strategy. By the way, these are all my studies. One's done on me, so
these are brilliant, by the way.
You know, how flawed I am. This is histamine, and I'm going to explain how to look at this. Okay, you'll notice that these little green arrows here tells you the cofactors here. So SAM, S-adenosine, copper, calcium, water, zinc, B3, B6. So when you want to create histamine, histidine creates histamine through, this is histamine decarboxylase. Okay, and then when histamine is created, it goes into storage in various cells and is released by stimulation of one of these receptors. Now, when you see the purple here, these are things that slow down the release or slow down the enzymatic function, and in the orange are things that kick it up. Okay, so once you have the histamine running around, It'll either go outside the cell, has to be broken down, or inside the cell. Let's go outside the cell. This is where most food allergies and stuff are. This is first broken down by DAO, which is diamine oxidase. Okay, my particular polymorphisms, which is, this will slow it down. That's how Dr. Ben Lynch created this. Okay, by the way, I actually created strategy, and then he developed it because he's got millions and I don't. Simple as that. I'm serious. So diamine oxidase takes histamine and creates an aldehyde. Don't worry about the big word. Aldehyde, think of formaldehyde, okay, is very injurious to the body. Okay, and then aldehyde dehydrogenase breaks that into acetic acid, which is vinegar, that can get excreted. Okay, and in me, it's going to work slowly because I have a lot of polymorphisms there. So what do? Other things that can make it work slowly is gut inflammation, metformin, alcohol, acetaldehyde. Acetaldehyde, alcohol gets converted to acetaldehyde and then gets converted to acetic acid, but very often gets stuck in the aldehyde stage. Okay,
very toxic.
I treat a lot of alcoholics and a lot of drug addicts. Okay, because something called reward deficiency syndrome, which you were alluding to, but that's another talk completely. Okay, and one of the things that was an eye opener for them was to realize that when they had more than an ounce of alcohol an hour, they were building up formaldehyde. And then they realized, I said, what is that? Embalming fluid. Then you see tear in the hairline. And that makes sense because it's going to injure the brain. That's where you get liver cirrhosis from. Okay. So the way that the only thing you can do for these pathways is slow down the creation, okay, the stimulation for it, because one of the feedback mechanisms is if you have enough histamine, it's going to slow down the production, and then giving these pathways what they need to work. Inside the cell, you have two pathways, a little one that goes to acetylhistamine, okay, which gets excreted, and this one inside, which is usually the histamines in the cells. H&MT creates methylhistamine, the MAOs create the aldehyde and aldehyde dehydrogenase. The reason I like this kind of study is you can simply look at this and say, look at this purple zone. This person's going to have difficulty breaking down histamine. Okay, why is histamine important? Next slide, please. Okay, by the way, this is how this got created. So you see all my DAOs, okay, and out of the 6 DAOs, I have 3 polymorphisms that are pretty nasty, so it went too slow. My aldehyde dehydrogenases putting together, his algorithm said that it was going to work slow. Okay. And that's, one of the ways of looking at how you can make that assessment of whether it's going to be slow, fast, or normal. Next, please. And histamine is an excitatory neurotransmitter. Okay. And it can be responsible for various conditions, especially different brain functions, arousal control, pituitary hormones creation, suppression of eating, so forth and so on. That's why some of the pills that you take to help sleep, histamine because it makes you tired, but also interferes with your ability to interferes with your hunger. Okay, so histamine also, just so you know, breaks open cells. It's purposeful. The mast cells, MAST, have granules of histamine and heparin. So when you get an injury, they release to open up the blood vessels to pour healing elements in there. Okay. And if you control that a bit with cold compresses, you won't have all that swelling after an injury. Okay. Because once that gets in there, it gets kind of stuck and it takes a while to go away. The histamine is important. It is something you need, but too much, or the receptors being hyperreactive because of a lot of inflammation, and you get mast cell activation disorder, which means less stimulation will make those mast cells release the histamines, called degranulation, very quickly, and then you get these major histamine releases. So always think balancing your system. Next, please. There's no reason for this. I just thought this guy was cute. Okay. I had this picture of this guy saying, mom's going, where'd the kids go? And I'm just going, they went that way. I couldn't help it. He was very cute. Next. Okay. Let's talk about methylation. That's usually the second word on anybody's lips when they talk about genetics. What is it and why is it so damn important? Okay. Methylation, very simply, is a better set of pathways that end result is S-adenosylmethionine or SAM. That is the methyl donor. And on one of the next slides, I'm going to show you that we have a genome, which is your hardwiring, that's very protected. We have an epigenome, which is where all these processes are, the dopamine, the neurotransmitter pathways, methylation pathways, and so forth. And the bridge between them, by the way, that's affected by the environment. The genome is not affected by the environment except for one thing, methylation. What does it do? It donates methyl groups, and the body goes into the genome and puts methyl groups on different things, different genes, essentially turning them on or off. You don't have to worry about that. Why? Your body knows what to do. It innately goes for homeostasis, in other words, a balance. So you don't have to control it. The only thing you have control over is the production of SAM. Next, please. Here it is. Okay, so graphically, let me show you that the genome, the green guy on the bottom, is very protected and does not interact with the environment. The epigenome interacts with the environment. This is the pathways we've been talking about. Methylation is the bridge between the two. So, next slide. Okay, this is my folate pathway. Okay, now when we talk about MTHFR, it is one enzyme in this pathway. And let me explain to you how this does. We're just going to go down the middle and not go to the side pathways. The SLC1981, that enzyme pulls the folate from the gut into the pathway, creating dihydrofolate. Then the next enzyme creates tetrahydrofolate, and then MTHFD1 and DF1L start creating all the fancy names. Okay, until you get to this end result, 5,10-methylene tetrahydrofolate, where methylene tetrahydrofolate reductase reduces it to 5-methylfolate, which is what we use. Okay, this pathway needs NAD, B3, okay, and ATP, which you get from your mitochondria, to work. Also, it needs folate that can be absorbed. Okay, that's a big deal because green leafy vegetables, that's tough. Okay, so a lot of times we don't have folate, so you don't have substrate. The way you supplement for that, by the way, is this pathway over here, folinic acid, which by methylene tetrahydrofolate synthase creates eventually 5,10-methylene tetrahydrofolate. We never ever use folic acid. Okay, so you need B6, B2, and zinc. Next slide.
Interesting. So what if you don't absorb those from, like some of the, and I know, like, I don't know if we're going to continue to get in this, but some of the I think you said there's over 50 MTHFR variants or SNP variants. And
yeah, there are.
Some of them affect the absorption of these. So what,
think of it this way.
Yeah.
Okay. Think of the conglomeration of MTHFR. Okay.
Yeah.
If you have, let's say you've got 12 looking at you on the study, and you've got one polymorphism.
Yeah.
The function of MTHFR is not going to be as, it's not going to be as significant as if you had 10 polymorphisms. Then you'd say, hey, it's going to work slowly. Okay. And you need B2 and B3 to work this, but it's a conglomeration of things. Sadly, they only look at C677T and 1298C.
Yeah.
It's still what it is. It's the traffic, substrate traffic, and cofactors, okay, which is what you have control over. Okay. So in this particular methylation pathway, after you create methylfolate, you have to create methylcobalamin, which goes in an MTR. And then you create this green methylcobalamin, these TCNs transported around. But all these different things, which I cannot see now because it's too small, okay, things like arsenic, reactive oxygen species, cadmium, lead, and so forth, will slow down the absorption of B12. And yeah, if you don't have B12 from your food and you take vitamins that don't get absorbed, okay, you're not going to have the substrate cobalamin to create methylcobalamin.
Right.
Then the methionine pathway creates SAM. Now, I'm not going to go into these little things that contribute to this, but all of these things together create SAM. Methylation is not just folate. It's not just cobalamin, but often people treat with 5-methylfolate and methylcobalamin and maybe SAMe. And if you look at my pathway, okay, it's going to work slowly to begin with.
Yeah.
So anything I do is going to slow it down more. If I'm not taking my vitamins, if I'm not digesting my foods, okay? If I give somebody or give myself 5-methylfolate, I'm going to have to do it all the time. Best thing to do is to fix my digestion, make sure that things are breaking down correctly, and giving this pathway what it needs. Remember, when I was a baby, it wasn't a problem.
Yeah.
Because there was no traffic. Okay? Next slide.
Yep. Okay.
So we want to take methylation hormones and dopamine together, okay? Again, dopamine creates controls libido. It reduces testosterone, okay? It basically helps balance the sex hormones. And chronic stress will affect it. When you have healthy methylation, dopamine production is good. You have clean estrogen and prolactin and your balanced hormones. But when you have poor methylation, that contributes also to low dopamine, estrogen dominance, and hormonal imbalance. Next. This is your hormone pathway, and I'm going
Dutch test.
explain.
Dutch test.
Yeah. It looks like a Dutch test.
Yes, the Dutch, right? Cholesterol creates pregnenolone. Pregnenolone will create progesterone. Okay, and I put in the enzymes or the I'm sorry, the genes that are responsible for it. In this particular case, the progesterone is very low. I don't know who this is. I took it as an example from the internet, but this looks like a menopausal woman. Okay, then pregnenolone will create DHEA, dihydroxyepidendrosterone, which with it, androstenedione creates testosterone. Testosterone through aromatase becomes estradiol. Okay, that's the basic part of the pathway you need to know. And guess what? It can be genetically involved, but again, stress and oxidative stress, okay, will affect aromatase and the other enzymes, specifically aromatase, because that will kick up estrogen, as you can see on the higher side here. So this person's probably prone to estrogen dominance. You also can, with the Dutch test, understand methylation and so forth. Next slide, please. So where we have control. We have control over the creation of the methyl donors and thereby have indirect control over our hardwiring. And we have direct control over our epigenetic pathway expressions by altering our environment, cofactors, coenzymes, toxins, microbes, all the psychological, spiritual, and emotional traumas, and our digestion, our enzyme, all the things that you guys do to help somebody become healthy. And if they're healthy but become better, okay, that's what we have to direct control of, okay? So if we don't pay attention to those factors, the body goes into chaos. Next. Hang in there, guys. I'm almost done.
No, I think
Okay.
everybody's
So
enjoying.
here's a good one. Genes, this is something you should know. Genes load the gun, genetics loads the gun, but environment pulls the trigger. And that also means that lifestyle pulls the trigger. Okay. The role of nutrition is optimizing the pathway function. Next. And again, this is just a different view of the same thing that I've been talking about. What we need is absorbable folate, absorbable cobalamin, absorbable vitamins. When you take liposomal vitamins, they get directly into the cells. Okay, it bypasses leaky gut, it bypasses all the problems, and now you're giving the mitochondria what it needs to work. Next.
So liposomal is just going to absorb through the through your
Mucous membranes.
Yeah. I'm having a brain fart, but yeah. So it just absorbs differently. It doesn't go through digestion. Why am I having a brain fart?
Right, exactly. The liposomal vitamins I use, which I actually use when I'm doing live blood cell analysis. Okay, I'll do a blood spot test and then give them liposomal vitamin, and then 5 minutes later by the clock, I'll test again, and you see all kinds of changes because it gets in and gets around the body in 5 minutes, and then I can tell what's happening inside the cell by the differences. Here's the thing that everybody should know of why you need to work with H4M and your practitioner. When somebody is in the middle of a bell curve, that green, we have mechanisms called homeostatic or allostatic mechanisms that will balance you. Think of them as buffers. Okay? But most of us who are ill are way outside that, the 14 and the 2%. And what a practitioner or what we need to do is march somebody back to that middle. That's why you need professional help, because you need to get from here to here, and then the body will take care of it. So the goal here is to balance the system to the point, take care of the root causes and everything else, to the point that the body can now treat itself. Next. Thank you, Chris. Last slide. Yep, that's me. I just wanted to say thanks.
Good. We'll
Okay,
put
for
that
putting
in.
up with me.
Yeah, this will be in the show notes, you know, how to get in touch with you, and I hope people watching do.
Yeah.
Yeah.
So anyway, if essentially genetics gives you direction, okay, and gives you an idea of how somebody might express. Now I'm going to teach you something really, really interesting. If you have someone, let's say a kid, okay, and you look at all their pathways, just, oh my God, I don't know how these pathways are going to express. You find out who in the family looks like them. And that, let's say Grandma Gail, okay, who looks like them, okay, because they're going to have generally the same genetics, okay, or at least the same expressions of the genetics. Whatever problem that person has, the person you're treating probably has that problem. That's the way it's going to express. You look at the dopamine pathway, you can see high dopamine. How's it going to express? Anxiety, psychosis, what?
Yeah.
Right. What controls that? The amount of dopamine which is created from the oxidative stress.
Yeah. So, like on this note, right? And you kind of brought this up before earlier in the presentation. I wanted to stop interrupting, but so I want to show.
No, it's fine. Please interrupt. Ask questions.
I want to show. So this is just a simple. This is actually our co-founder, Todd Hitt's genes, and he's got all these genetic things. I was just picking glutathione because it's an easy one. It's easy to understand this concept, right? So look at all of these SNPs down here, all these polymorphisms, right? And all of this they came up with, and this is what the kind of the gene testing company came up with to tell us, right? Glutathione level propensity and NFR2 activity. NFR2 is a master regulator of defense, right? Reducing reactive oxygen species, does a lot of things. But they kind of just told us these two simple things, right? And when we first saw this, we said, this is not actionable enough data. You're taking these SNPs, which actually have a lot more data. There's actually a lot of information in all of these SNPs, right? And to just kind of boil it down to this is pretty facile, and we didn't like that. So we originally said, listen, we don't like this. We want actionable data. What do I take all of this genetic information and tell me what to do with it? And so that's why we created an extra large language model machine to actually parse through all this data, give us all the information, and synth it with your blood work and your personal history and all the data that we have, and be able to synthesize real, actionable, deep, customized data for you, right? Instead of just kind of giving this general information. So exactly what Dr. Armine was talking about, look, we have all these, what does all this mean? It's hard to understand, but there is a lot of data, in all these SNPs here, and we just wanted to give you better information on that. So that's something that we do, and that's unique to H4M. No other company is taking data, synthing it through the software that they've created. We've had now I can't remember the name of the company, Brandon. What is it?
SG Analytics. They're one of the top.
Analytics.
One of the top data firms in the world to custom build our LLM. Now, that being said, I would like to briefly share an example of what the output looks like. I'm not going to go super in depth here, and this is not the sexy version that our patients will get to see. This is just raw output. But if we go through it, you will see that. Oh God, can I even scroll on this thing? Okay, yeah, I can. Sorry. If you go through this, you'll notice that it is intake, the patient, in this case, Todd's, his protocol as far as his medication goes, so his hormones, and then it takes into consideration his, genetic proclivities, as well as the hard data, the impact that we see in his blood work. So we're going between all of these, and we're drawing real-time conclusions as far as how should we implement this with his nutrition. Of course, he's a nutritionist that gets this data, and then she uses her expertise to formulate her own opinion. But this is kind of the raw output. And then it also includes what should his exercise program, what should his supplement regimen look like. And Todd will be the first to say that he's felt better and better and better as our protocol has been continuously refined for him. So I probably at a later date, we'll do like a deep dive into this, but I just want people to see, so it's not just abstractionists talking about it, but there's a hard product that gets in the hand of the patient at the end of the day.
Yeah. And we're the only company that's like synthesizing this data with really brand new technology and software. So now
there might be
into a health.
There might be some there might be some other ones out there throwing your information to Chat GPT, which by the way then just frees it up to it's essentially putting your information on the internet, where the folks at OpenAI can do with it as they will. Whereas ours is gated, it is locked down, it's not going anywhere.
Well, and it also ChatGPT is just going to hallucinate with all this information.
Correct. Yeah, it's
going to give you great data.
You are asking the common denominator of the most Googleable result what their opinion is, which I think Dr. Armine will tell us is probably not the best idea.
Yeah.
Not really. But I'll tell you one thing. The real benefit and the necessity is correlation. Okay. What we talked about before is that your program there is correlating all the factors. Okay. And because it's not depending on averages of what's out there, okay, it's going to be more accurate. And then of course the professional is looking at it and saying, this is more relevant than this. So you start skewing your treatment plan to what's more relevant, and that takes the professional eye and your history and so forth. So your results are a jumping off point. Okay, but when they're this tight and when you're correlating everything, that's what has to be done. Okay? That's what's not done these days. Okay, you can go to a Lyme practitioner and they treat Lyme, and since they treat Lyme, it's like having a hammer. Everything looks like a nail. Okay, you go to a methylation practitioner, they're going to give you methylfolate, methylcobalamin, SAMe, and that's going to be the extent of what they're going to do for you. Or they're going to give you methylated vitamins that have everything in there. So everybody's got a methylation problem, not really. Okay, because you're not looking at everything else. Correlation is the key.
Yeah. At the same time, of course, there is some benefit to targeted supplementation when done intelligently. So that is something that if you're watching, it's a good idea to go ahead and click the links that will be in our description to go to goh4m.com. Go ahead and click the button in the top right that says get started, and go ahead and get started with us. That way you can work one-on-one with somebody to get all these things corrected for your unique circumstances.
That's very good. Absolutely necessary.
And speak of the devil, Sean, yes, indeed. The second you get those blood results in, we'll crank out one of these for you and we'll go over it in detail.
Yeah. So there's some good questions we came across. So let's start hitting some of these questions.
Okay.
This is an interesting one. I have you start to, being in the industry we're in, we start to learn about the demonization, the stigmatization of testosterone, right? And about how it's actually one of the most beneficial medications in the history of medications. And it was just, misinformed against, unfairly demonized, unfairly stigmatized, fear-mongering, right? And you start to learn that testosterone is not the only thing that's happened to, right? There's a whole history of that happening with marijuana, right? But also especially like MDMA, and I think that the government just like a few years ago opened up experimentation with MDMA, because MDMA was put into a Schedule I drug again because the freaking government just runs on this platform of war on drugs, and then they just control everything they can and say, and the Schedule I specifically limits people from being able to even experiment with it. Like we can't even try to see what happens. So MDMA is actually very interesting, and it's had a lot of positive effects for especially like deep-seated PTSD patients from the war, right? And it's had like really, really beneficial effects. And so No Waker here is asking, can you share anything interesting, non-obvious about MDMA? Like, I don't know how much you know about MDMA. I mean, it is an amphetamine. But like, is there
what I know about it is that it's an amphetamine. Okay?
Yeah.
If I had that question prior, I'll be happy to do a bit of research on it. But I don't know anything interesting and non-obvious right now. Okay.
Yeah.
So I never lie when I don't have
That
it.
is the mark of a true
Yeah.
expert, is
That is
admitting
true.
when they are, within or without their scope.
Yeah, it's important.
There-
Yeah, it's important to say it when you don't know. So I
I
do.
respect the hell out of the answer.
Yeah,
I never lie. I never lie.
I mean, anybody who's ever done MDMA is just fantastic. Right? And
I was not going to report
and,
apart from the obvious. Yeah.
but
Yeah, it's something that's really interesting. Things like LDN, low dose naltrexone. There's all kinds of different things that have really interesting effects on various cells and various receptors and so forth, and it's amazing. But I'm just
LDN
not
is great.
on MDMA.
you know what?
It is.
Another thing that was highly demonized and almost intentionally like misinformed so that it would become less like when you really do the research on this, it's like it's pretty crazy. Like it looks like it was intentionally demonized so that people wouldn't use it because it's better than current medications. Is GHB. GHB.
I was thinking it. Oh my God, I'm so glad you said it.
You're
GHB.
your homeboy.
GHB is like an
I
incredible.
remember when that came out.
Yeah, it's like incredible, and there's a massive benefits that come from it. It's not nearly as dangerous.
I think the date rape thing was entirely fabricated
It
to
was
give
fabricated.
it an excuse.
It's totally
Yeah,
fabricated.
because one, it is a very distinct flavor. Nobody's getting that snuck into a drink. I'm sorry, it's not
But it
happening.
doesn't knock you out like to the point where like it's not a roof like Rohypnol. It's not like that.
No,
It
no,
doesn't-
no, totally different. Now, Rohypnol has a deserved reputation as far as I'm
Yeah,
concerned,
but
but
they put it in the
GHB,
Rohypnol category, and it's not like that.
yeah, GHB, I firmly believe, and I hate to get my tinfoil hat out, but it stays on. I firmly believe that they use that narrative and they use the public ignorance to get rid of. By the way, it's endogenous. It has its eponymous ligand. It has the receptor. We have a GHB receptor, so it is.
Yeah.
It's actually
it's part of the butyrate family.
And
exactly
it was the answer to many serious sleep
problems.
disorders. Like now they use Seroquel. Like, do you know how awful Seroquel is?
Or like what Ambien actually does to a person?
That's
Yeah, I mean it's outrageous.
Ambien is worse. And let me tell you something. And they're using things like they're using Miralax, they're using polyethylene glycol for things. It's just a matter of what they can sell. Your the gamma hydroxybutyrate, the bigger problem. They had it, of course, in the weightlifting community, and we're selling it as something that would release growth hormone.
Yeah, because it does that.
You get great sleep. You do.
Yeah, but when you take it in a certain dosage, you get kind of knocked out quickly.
Yeah,
sure.
But it's very efficacious for sleep disorders. Like where instead of using Seroquel, you should use GHB because it doesn't have nearly the adverse long-term consequences.
Along with human growth hormone, it's one of the few compounds that we know of that simultaneously increases REM sleep and deep sleep.
Yeah,
it's very unusual to find something that does both without sacrificing the other. So, yeah, like the idea that it was made illegal because of its risk profile is ridiculous.
Yeah, it is.
Well, remember that there's more money in treating cancer,
of course, and how many hundreds of millions, if not billions, are sold in these sleep medications?
Yeah.
So yeah, I think it's very obvious.
And they're incredibly dangerous. Like Ambien is not supposed to be given for more than 2 weeks, but people are on it for years, and it's a sedative hypnotic, and especially for the elderly population. They'll go out and do stuff and not even remember that they did it.
Yeah, it's
cook and it's terrible. And it's great if you taking it occasionally, but not on a regular basis to go to sleep.
Yeah.
Plus, you're burning out receptors. You're not getting to the root of the problem of insomnia, which is what needs to be done. Okay, so you're gonna end up having to use it all the time.
Yeah.
Obviously a passion point for all of us. I'm glad we're in agreement. I'd like to move
Yes.
on to something very interesting that you brought up in
Yeah.
regards to the spike proteins. To whatever extent you're willing to share, would love to hear more.
Well, I'll be happy to tell you all about it. The paper that I did was on augmented NAC and Dr. McCullough's spike protein, which included things like nattokinase, lumbar kinase. And but what has been scientifically shown is that, first of all, the spike protein is a toxin, is very pervasive, and the spike protein from the vaccine is much more powerful. And what ends up happening is it ends up interfering with mitochondrial function. There's only been one substance out there that has been scientifically shown to denature the spike protein and pull it off the receptors, and that's augmented NAC.
Augmented.
Okay, N-acetylcysteine is a substance you can take. Okay, that will denature the spike protein, but it's usually a supplement that will help you create glutathione. What it does is it binds with glutamate, which is a great way to control high glutamate, by the way. Okay,
which a lot of people have. Yeah,
very many. And the reason that's safe is because when you're producing glutathione, okay, the body will control it with a negative feedback mechanism if you give them NAC. But if you give somebody glutathione, when it breaks down very quickly, you're releasing glutamate. Also, once you create glutathione and it gets used up, it gets oxidized, we have a mechanism that recycles it back to the active glutathione. And often, if that mechanism is not working well, you get a buildup of the oxidated glutathione. You start interfering with mitochondrial function, but that's another issue. Augmented NAC has been shown to denature the spike protein. What they did was they did in vivo studies with tissues that were filled with the spike protein. They actually bought them and brought them in. And they used regular NAC and it denatured the spike protein by 18% in 24 hours, where the augmented NAC denatured the spike protein at 99%.
Wow. I'm sorry. So how are they augmenting the NAC?
Okay, that's the first question I get, and it took me a while to pry it out of them. Okay, there is something called quantum coherence, or what I'm writing about now, comparing the two. This is my next paper, comparing regular NAC to augmented NAC. It's called bioenergetic coherence. Now, when I started learning about that, I was like, yeah, right. Okay, right. I'm cynical until you prove it. So I went and did some research and found out that things are quantumly coherent, which is the difference between a flashlight and a laser. Laser is coherent light, flashlight's all over the place. Okay, and of course the incoherent is going to be less powerful than the coherent, as a laser would be. So there are things in nature that are more coherent, more quantumly coherent than other things. Okay, and they say, oh, they have a process that creates the quantum coherence. I'm like, yeah, right. And they were very tight with their information. I had to pry it out of them. Because they were afraid that people would take their process. I understand that. Okay, but I was telling them, because I write papers, for the zero spike people. Sometimes I'm like, you got to give the scientific community something, right?
Yeah.
So I found out by corollary research that there are ways of creating something to be more quantumly coherent, and that's the process they're using to make. So how do we know this works? Well, the augmented NAC comes in 100 milligram capsules, and believe it or not, has the power of about 2,400 milligrams of the standard NAC. And if you want to denature the spike protein, I use this in my practice, and I can tell you that it works. The augmented NAC twice a day, okay, for about 3 months, will start denaturing the spike protein, as long as you're doing everything else. But to specifically, now Dr. McCullough's work also works very well, but not as well as this. I wrote the paper with Dr. McCullough, okay, and we agreed that the combination of the two is probably the best, okay. But if you're comparing the two, then the augmented NAC, if you had a choice between the two, and you say, I can only afford one, okay, it would be the augmented NAC, because that has been shown. Although the nattokinase and everything else that he puts in there does work, but not as powerfully as the augmented NAC.
Very interesting. Do you have a place for people to get that, or should they just get a hold of you?
My first
sure.
question.
If you go to augmentednac.com, okay, you'll see they have places where you can get it. Okay, and that's where my patients get it from and stuff.
Brilliant. Thank you for sharing that.
Sure.
That's great.
Because I know there's not a huge amount of our patient population, but long COVID, et cetera, concerns about exposure to the vaccine are that's certainly something that we see a bit.
Okay.
It's really simple to diagnose. They just came out with this a test, a urine test that can look for the spike protein, but
Okay.
just wrote the protocol on it, and it's like in the next 2 weeks it'll be out.
Okay.
I can't wait for it to come out.
Yeah, that's
Can't wait
great.
to see it. Moving along, role for phospholipids like choline, and then another interesting supplement is the plasmalogens.
Okay, well, I'm not familiar with the plasmalogens. Just tell me what that is.
Sure. So
the
they
phospholipids.
are, they're a form of phospholipid. I have forgotten quite a bit about them. Unfortunately, I was not taking notes. I was watching a video, but there is a doctor that noticed that these decline precipitously with age, especially in people with Alzheimer's, dementia, etc. They are, apparently foundational to neurological health and general like cell membrane type health. So to answer Chris,
So
I think
they're
the
a
answer is yes.
form of it's a form of phospholipid.
Correct.
Well, generally speaking, phospholipids like phosphatidylcholine, okay, are your cell membranes. They are a phosphatidylcholine bilayer. Okay, things like lecithin that have phosphatidylinositol, phosphatidylethanolamine, and phosphatidylcholine, but the phosphatidylethanol and inositol create the phosphatidylcholine. In your pathway where you saw the SAM, there's another gene over there called PEMT, phosphatidylethanolamin and methyltransferase. They use the SAM as a cofactor. That's how you take your lipids and create phospholipids. Okay, but if you don't have phospholipids, and there are certain things like cardiolipins and phospholipids, so forth and so on, that are necessary, especially in the mitochondrial membranes. Okay, and the ability to absorb lipids and convert them to the phospholipids is important for all the cell membranes. And neurologically, it's mostly the covering of the nerves, okay, the neurolemma, and recreating that, because as the nerve, think of that, the difference is, think of a wire and then think of a coaxial cable. Okay, it's a little wire with a big thick. Okay, when you have a nice big thick covering, the impulses go along very, very well. Okay, when you don't, you get these little. How do you know the difference? We have both kinds in our body. Okay, we have C fibers and A fibers. Okay, and one of them is slow, one of them is fast. Okay, so when you put your hand under hot water, you go, and then 3 seconds later, okay, 2 different speeds. It works. All right, but what's the reason that it works neurologically is it probably crosses the blood-brain barrier and helps preferentially supporting the cell membrane structures. Okay, that is one of the things, because I created something called bioindividualized medicine that looks at genetics, neuroendoimmunology, mitochondrial function, and cell membrane integrity. Okay, it's a thought paradigm. So you make sure that you put all that together in your treatment, and you're covering a lot of bases.
I hope our patients forgive me, but I'm going to step in front of line of the questions and ask one of my own. So let's say I was coming in as a new patient, and I'm sure I fill out an intake form, which helps you better answer my question. But what tests do you typically run? What does that look like?
Well, remember that my patients, I'm not the first person they've seen. Okay,
so they have a bevy. They already have a bunch of different things.
Absolutely, I'm like the 30th. Okay, so what I do at first is I take a very long history, and I review all of their tests. Okay, this way I can target testing that is necessary. In other words, if I need to know something, like, hey, this looks like Lyme disease, I'll know which test.
We need to run this one-off test out of the plethora that you have.
Yeah, and because most of the things, I already know it's there. I mean, you look at it and say, okay, that's been checked. The nice thing about what I do is when they've seen everybody else, I can tick off in my mind what has already been checked adequately. I also can tick off in my mind what has been ignored. And then the stones that have been left unturned. And just like Sherlock Holmes says, when you rule out the impossible, whatever's left, however improbable, must be the truth. Okay? So it's a ruling out process. I don't have a standard amount of tests that I do. Okay? I read them and then I target what I need to know.
I was looking for an easy answer, and those rarely exist. So I appreciate that.
Not here.
Okay.
Yeah. This is yeah. This is,
I guess the question is the hypothesis.
yeah. So his wife was on. She's on some dopamine transporter inhibitors. She was on this cariprazine. She stopped the cariprazine and it unlocked like this emotional, like a positive emotional cascade, like positive emotions, and everything went really well. But then and that was like maybe 7 days after she stopped it, and then 20 days later, about 20 days later, I think it was, she just fell into this deep like depression, like inability to move, almost like this, like really, really poor dopamine, really low dopamine state.
Well,
No motivation, yeah.
That's a very deep question, because what ends up happening with some of the medications, let's put it this way, they'll build up, this is normal, okay?
Yeah.
They'll build up something to a higher length that makes them feel not so hot, but then if they stop it, they feel pretty good. Okay, but as it starts metabolizing out, it goes through the normal range.
Yeah.
And then down here.
Yeah.
And that's when the depression kicks in.
Right.
Now, a history on that, if you take a longer, extensive history, you can see where the patterns are. I live by patterns. Okay. And yes, it could be 5-HT1A antagonism or agonizing D2 and G3. But guess what? What do you do about it? You take that information and you say, now I'm looking at something like receptor inhibition.
Yeah.
Okay, and that's usually chronic inflammation. Okay, you take the history of what this is why it's important to know what the medications do. Okay, in that particular history of somebody stopping and they're go through where they feel really, really good and then drop, what's going on when you see what happens.
You see cases too also of people who take too many dopamine transporter inhibitors or dopamine reuptake inhibitors. If you take too much of that, you can just desensitize to dopamine completely, right?
Temporarily, yeah. And it all depends. Remember that desensitization of the receptors is a problem. Okay. For instance, the D2 receptor is responsible for many problems. There is responsible for things like neuropsychiatric diseases, autism, so forth and so on. It's called reward deficiency syndrome. And that is, the research on that has been extensive. But what that is a polymorphism at DRD2, which runs the D2 receptor. And then there's this thing called the brain reward cascade, which serotonin starts and then eventually becomes dopamine. There's a whole cascade of things. And every time the stimulation gets in, it needs more stimulation to get through. All right, so what do you do about that? What makes this worse is inflammation. Okay, all you can do is fix the pathway as best you can. Okay, so that each stimulation creates the result. Here's the problem with these receptors, and that's why people have bad responses in the reuptake inhibitor range. Okay, serotonin reuptake and norepinephrine, dopamine. If you don't give the body what it needs to produce the neurotransmitter, all it's doing is preventing some of the reuptake in the synapse. And as my mother would say, if you ain't got it, you ain't got it. All right. So if you don't have enough serotonin, because these medications do nothing for the production. Okay. They will continue to inhibit the reuptake with the thought of keeping the target neurotransmitter in the synapse. But once those warehouses, the vesicles are empty, which does happen, and once you're just simply not producing it, you're not producing enough, those medications will fail. And then they start going into the atypical antipsychotics. Okay. And that's why that becomes so wonky. It's a neurological soup, which my friend sent to me because I love that kind of stuff.
Yeah. Do you ever have any success with, because sometimes you can just get on this path of taking too many of these things, right? Like you're taking a dopamine reuptake inhibitor and selective serotonin reuptake, another antipsychotic, and like you're just taking all these things. has ever a tactic of yours been like, I mean, it's going to suck, but let's at least wean off of or come off of everything, and then let's start over. We gotta kind of start over.
Okay. Your point is well taken. Your question is a good question. That depending on the expression, you have somebody who is psychotic and you cut off their medications. It doesn't matter how well you feed them or whatever you give them. Yeah. It's not going to build up anytime soon. So here's the way that I usually work, because that's exceedingly dangerous. Okay. They're on their medications, right? I start fixing their body. And this is what you guys will do. You'll fix their body as best they can. And then they're going to start feeling better. Okay. They can go, and believe it or not, psychiatrists do not like polypharmacy. They do it because that's the way they were trained. I'm sorry. That's the way that when they give them medications, then they have to handle the side effects. Right. So what I usually tell the patient to do, they'll go up and say, right, with medication. So I'll tell them, listen, I feel better. Can we start cutting down on these things? Psychiatrists, oh yeah. What they'll do is to start dropping one thing until it's not necessary, dropping another under their supervision. This is safe. It may take a year, but at the end of that, you've built them up so their body is back in that middle of that bell curve. Yeah. Okay, and if they're on a medication, because remember, a doctor of medicine is his or her armamentarium. You're not going to talk them out of it. Reminds me of something from Mel Brooks. Sorry. I have the keyword brain. Sorry. Okay. But so if that patient's on one medication at the minimal dosage after being on 5 or 6, right, and their body's working better because of your interventions and their efforts, that's a good goal. And if you can do that safely, you know, and if you wanted to just drop all the medicines, they have to be in an inpatient facility that can handle, you know, seizures and stuff. I mean, some of these reactions are nasty. You don't want them to do that on their own.
For a psychotic, yeah. We do have a follow-up question.
Sure.
So which medications are your favorite for dopamine? Dopamine releasing agents, dopamine reuptake inhibitors, dopamine antagonists?
Different answer than Dr. Freud, I would assume.
I don't have a favorite. Okay, no. I treat the body's ability to create dopamine and balance the neurotransmitters. Okay, so it's what they're on. You know, remember, a doctor of medicine, they're trained to do all this stuff and they have all these considerations. It's fine. Okay, I look at it from the cellular point of view. Okay, I start fixing the reasons that the dopamine was up, now it's down. There are dopamine releasing agents, which I'm not really fond of. Reuptake inhibitors are more easily controlled. The agonists and antagonists, it all depends. Okay. There's a lot of medications that affect multiple receptors. Okay. What I like to do is look at what the medications are doing. I ask them which medications worked better for them, which did not work well, which they reacted to. And knowing what they're doing with the different receptors tells me about the neurotransmitter balance. I'll give you a cool example. If somebody says when they drink alcohol, they felt calm and so forth, okay, GABA release. But if I ask them when they smoke marijuana, how they feel, and they go, ooh, it makes me feel terrible. Why? Well, marijuana releases GABA, but it also releases dopamine. That's why when you smoke a lot of marijuana, you get paranoid. But if your dopamine's already up and you smoke a joint, it knocks you right into the symptomatic range. So when you hear that, you say, okay, that person's got high dopamine. Okay? So sometimes you can do it on history. Here, again, I don't utilize medications in my practice, but I do know the reason that these things don't work or they need to be supported is to now go into the cellular, the receptor function. It's all oxidative stress.
Yeah, that's really interesting.
To help contextualize your answer, I think if I understand you correctly, somebody's already coming to you on probably quite a few medications. So you're helping clarify which ones work best. And then how do I build your biology up in such a way that you require less so you can work with the prescribing physician to taper down, wean off, et cetera, so on and so forth.
With the presumption that they want to wean them off medications because having them on multiple medications.
I don't trust the physician to taper people off medications.
That is a reason to. And you have to provide the reason, which is the patient themselves. Hey, I'm feeling better. And they go through the various symptoms. Okay, let's try this, because the patient simply wants to say, listen, they don't want to stop it. If they want to do it under supervision, they simply have to ask the doctor. The doctor's going to ask them,
Why?
a lot of questions. And if they're convinced that, okay, this is worth a try, then they'll do it. And as they work on let's say the least, ridiculous medicine, they work their way down, they find out the person doesn't have a negative effect, then we'll go to the next medicine. They're not stupid, okay? And you have to realize, you have to respect the fact that they know what they're doing, and that's the way they're trained, okay? I never yell at somebody for doing what they've been trained to do, okay? But I know what they're trained to do, and I see where the issues are, and I try and fill in where the stones have been left unturned. I don't sit there and yell at them, okay? I sit there and say, okay, how do we go back? And this is what I've done for a long time. And believe me, it's very successful because the patient, first of all, has control over it. Lack of control, fear, is what kills people. Lack of control is the worst thing in the world. When you start getting control over it and you start working with your physician, sometimes they ask, gee, what are you doing? Then I get a call, which is fine because I can speak medicalese. That's not a problem. And tell them exactly what I'm having. And since I'm not interfering with what they're doing, okay, only supporting the body, they're like, okay, let's see what happens.
I don't get those types of calls. The calls are like, what are you doing? These testosterone's dangerous. I'm like, no, it's not. Here's 100 studies.
And you know that, and that's great. And,
we're like, our clinic is specialists. Let us deal with the hormones. You deal with everything else.
Just remember that if you control the NEI, if you control the hormones, it's going to affect the immune system and the neurotransmitters by its nature.
More lighthearted question from Anthony. When can we get some merch? The answer is, Anthony, for you, a lot quicker than everybody else.
Yeah.
We'll move on. This is a very good question.
Yes,
Dr.
I'm on
Armine
YouTube, right?
Okay, so you are on YouTube. We'll get that your channel plugged in there. And then any other forms of social media we should plug as well, or is it just going to be YouTube for you?
I have a personal Facebook account that's not technical.
People can leave you alone on that.
Yeah, and I'm on. I just started on Instagram, doing a lot of podcasts now, so I'm putting that on.
We're happy.
My YouTube channel is all the videos I've done. All the videos I've done on way different subjects. Okay, and hopefully they're entertaining.
You will be on my fasted cardio playlist for a good while, I'm sure. So I appreciate your contribution to that. Let's see. Would GABA help with that? Dopamine. I think what Anthony is asking is GABA's opposition to excitatory states. Yes.
GABA aminobutyric acid. GABA is the mammalian brain way of calming itself quickly. Okay. Now, there's two types of GABA you can get these days: pharma GABA and liposomal GABA. The pharma GABA won't work very well in the brain because it's water-based and won't cross the blood-brain barrier. But if pharma GABA does help, it tells you you have a leaky blood-brain barrier if the pharma GABA helps. The better way of treating that is using liposomal. Seriously, that's what it's helping. Because now it's crossing the blood-brain barrier, and usually if you have viruses, they create little holes in the blood-brain barrier, opening it up for other infections to get through, like parasites and so forth. And I've seen that also. Liposomal GABA universally works better because it absorbs right away, crosses the blood-brain barrier, and simply gives you GABA, as opposed to a benzo that's stimulating the GABA A receptor. Okay, and that ends up being getting damaged. And that's why benzos tend to be bad. Plus the fact that the stimulation of the GABA A receptors, like that McDonald's off the highway, fast on, fast off. Okay, so you end up having to take more and more and more. And again, you have to get to the reason for the excitation. Okay? And if you build up serotonin, then I suggest you use 5-hydroxytryptophan. Tryptophan creates 5-hydroxytryptophan, which creates serotonin. Okay, but tryptophan can be pulled out of the pathway by inflammation to a different pathway, called the chirenic pathway, and eventually create quinolinic acid, which is a hell of an excitotoxin. But if you start with 5-HTP, 5-hydroxytryptophan, you'll create serotonin right away. They even have liquid forms of that. Okay, and there's a liposomal one by Epigenetics, but liquid form works really, really well.
Yeah, well, all that makes sense. Like, what do you think? I mean, using nature's like nature's GABA receptor, positive allosteric modulator, GABA A receptor, which is progesterone, right?
Mm-hmm.
So that will pass the blood-brain barrier, and you just use progesterone.
Yeah, you can do that. There's a thousand ways of going about it, but
downstream.
But it's good. You have a methodology of doing the same thing, which is great. Plus balancing the nutrient, balancing the hormone system.
Yeah, and estradiol increases tryptophan hydroxylase, which is the rate limiting step to increase serotonin, right? So yeah, you're right. There's a lot of ways to do it. I like to use the hormones, but certainly
and downstream.
The hormone, remember about the hormones. If you don't have substrate, it won't work. Okay, so it comes back to you still need substrate.
Yeah,
support the biology.
Well,
that's why if you do it all together, if you just
all of it together, but you do learn that phasic spikes in serotonin are solely due to estradiol. So you do learn that these hormones are foundational neurological signals. They actually, like, testosterone is solely responsible for the phasic spikes in dopamine that gives us the ambition, the sense of well-being, the motivation, and that we think of when we think about, and libido too. Phasic spikes in the nucleus accumbens, the bed strata of the did I say that wrong? Bed nucleus of the stria terminalis, right? That's one of the libido areas where testosterone spikes, increases dopamine. Medial preoptic area. All these testosterone solely controls those phasic spikes, right? And estradiol estradiol also builds the neuronal backbone to receive dopamine as well. So like all these things come together, right? Like yeah, and you're right, and you need all the substrates too. So everything.
What you need is a holistic program that allows to give the body what it needs and what it needs to create homeostasis.
Yeah.
Okay, whether you go through that, the hormonal, the peptides and the hormonal way of doing things is, a powerful way. Okay. And if you're assessing everything to begin with, and you're taking into account all the factors that the body needs, that's what I talked about correlation before, then you're safe and you're doing a holistic program. Okay. Because that's what people need.
Mm-hmm. I just want to touch on Anthony's question, not Anthony specifically, but look, I love self-education. I get that's what a lot of people watching are doing right now. And I'm a fan of self-experimentation so long as it is with adequate education. Where I get a little concerned is you'll get questions where people say, oh, I heard this is good, so I'll take it. And I just want to remind people that this is what we're actually talking about, right? Like this is a lot. Like it's not just add GABA. Like there's the spider web has way too many filaments.
Yeah.
And if you pull one thing and you don't know what you're doing with the rest of it, you could inadvertently cause more problems than you signed 100%. Up for. Now, the GABA probably is a more innocuous example, but there are people out there that, nowadays with the peptides and the research chemicals and stuff, people like, for example, like housewives are hearing that tesofensine is useful for weight loss. That's a triple reuptake inhibitor. Like it's got an incredibly long half-life and it interacts with, oh my God, I can't imagine how many other medications. So like if you just heard your favorite influencer say that and you went and bought some through their affiliate link, great, they get 20%. You could end up with a panic attack. You could end up in the emergency room. So that's where I get a little passionate about having people like yourself on here, which I don't want to like make people seem like, oh, we have the answers, you don't, you can't do anything. No, I want, if you are going to do self-experimentation, at least treat this with the respect it deserves because it's your body and your health.
I've seen people instead of using, let's say, phenylalanine, I've seen people to build up dopamine and so forth when it's low, using phenylalanine and tyrosine. Okay, and some people will use L-Dopa, which is extremely stupid.
Yeah.
Okay, or use meconiopurins, which is L-Dopa, because it will take the dopamine and knock it through the roof. And I can tell you of cases of psychotic breaks within a few days of taking that because they overstimulated, they pushed the system too high. think of it as a car. You get an older car, and the water pump has to be changed. A nice new water pump, but they don't change the pipe. They don't change all the tubes. All of a sudden, they start blasting out because now you've got a nice, powerful water pump, but it's not used to it. Okay, there's a lot of interaction, especially in the genome. Okay, and remember, you pull one thing and something else may go on. That's why low and slow is the way to go all the times. All the time.
Yeah, little lacuna here
Dr.
and there.
Google, one
Okay.
thing. I'm sorry, one thing. Dr. Google, yeah, be careful of anybody who is selling something or
Yes.
pushing something specifically. Okay, I don't care how many letters they have next to their name. Okay, or how good they look on TV, or how intelligent they sound. By the way, the more big words that somebody uses, the less you should listen to them. Because my job as an educator and as a physician is to make you understand what's going on, not to impress you with the fact that I can pronounce polysyllabic terms. Okay, I can explain the pathways to you. You're not going to be impressed that I know them all intricately. It doesn't matter if I can show you what's going on, so you understand what's happening, and you can not buy into it, but understand your treatment. And guess what? The treatment's going to work. Right. Be careful. Plus, there's no magic bullet out there. Okay, there's no magic bullet. Sorry, that was my soapbox.
I enjoy it. And this is a very good follow-up question for you, doctor. What U.S. states are you licensed to practice medicine in, and do you do telehealth?
I only do telehealth. Okay, I'm licensed in Pennsylvania. Okay, but since COVID took all the curse off telehealth, my practice is entirely virtual. Okay?
You can pretty much do anyone in the country.
Yeah, I have a worldwide practice. I have patients in Australia, Japan, Budapest, a lot in the UK, Scotland, and time differences don't mean a lot to me because I'm set up for it. Except Japan and Australia. Oh my God,
that's a big one, man. I think Damien's
16
question.
Hours ahead, I'm like.
I think Damien's question partially stems from being a patient of ours, where with controlled substances, it's very different. That is more tightly regulated. So we have very specific practitioners for each state, but that's a function of them prescribing a controlled substance.
Controlled medicines are
for you.
That has to be
I would imagine, like you said, the gates are off, so you can do wherever. So that's great.
I'm using natural substances. I'm not using medications and so forth.
Right. Yeah. So you're supporting biology. You're not using medication so much.
Killing me. Where did I hear my name before? Okay.
Yeah.
Cross paths.
Did you know? Yeah. Did you know Reed Davis? It looks like Ruben's heard or has crossed your path.
I know who Reed Davis is. Okay. And I just finished a functional medicine course that I taught the Nutrition Collective in the UK, which was an online course. My name is bandied around because I've taught a lot of people. Okay, and one time or another, most of the people who are out there taken or have mentored them, or we've interacted at some point.
You've had a long career and touched a lot of lives.
Yeah, I'm happy. I'm very blessed. I'm 69 years old, so I've been around for a while. And half of my time is teaching and the other half is patient care. And I love, I've always loved spreading around the information and bending back different things, because what happens is you start getting a whole view of, hey, this complex person. And it's been said that the body is intricately simple and simply intricate. You have to respect it. In other words, give the body what it needs and get out of the way, because people who micromanage, that's just not the way to treat a body. But I remember functional diagnostic nutrition.
Well, I think that actually does got all of our questions.
Yeah.
So
yeah.
Good work.
It has been absolutely great to have you on, Dr. Armine. It's always.
Thank you so much for having me. I really do appreciate it.
I've spoken
likewise, man.
To you a few times now, and it's always thrilling, always fascinating. And we'll certainly get back to you to do some more education in the future here, and Zanuck learned a lot. I certainly learned a lot.
I will be binging your YouTube channel, and I hope many people watching this will join me in that.
Yeah, I want to let you know that you guys are doing good work. I'm very respectful of what you're doing and the time and education and the research you've done into it. You know, you didn't just take some of the protocols and just say, hey, I'm going to apply this. And no matter what, you're doing it the right way. And I have great respect for you guys. Seriously.
Thank you very much. Yeah, and you know, again, why we also wanted to have you on and want to have you on again in the future is because as you're doing this the natural way, the right way as well. So it's just always fascinating to talk to you. Okay.
Well, thanks so much. I had a great time. Thank you so much.
And thank you everybody in the chat here. It's great. Thanks for all the questions. It's great talking to everybody. Everybody in the chat is what kind of makes this show. We get to chat with everybody and have a great discussion, have a very educational discussion. And hopefully we helped some people here. I'm sure we did. Well, again, we'll put all Dr. Armine's information in the discussion. And again, it was great. Thanks again. Thanks, Brandon.
Thanks.
Great.
Thank you guys so much. I'll go ahead and send you all those links that you.
Visit goh4m.com if you are watching this and not a patient and you would like to become one or considering become one. We also do sell supplements on our website, and we also offer blood testing and genetic testing on our website.
Great. Thanks a lot again, everybody. Okay, we will.
Y'all take care.
See you later.